Good afternoon, everyone. Like to thank everyone for joining us for this special edition. Doing things a little different this afternoon. Have a fireside chat with Dr. Potsock. Um, Let me introduce myself first. My name is Dr. Shauna Snyder. I'm an associate professor at Gardner-Webb University in North Carolina. Um, I teach health and wellness, but I am also a patient of Dr. Potsock's. I have a fairly typical story. Symptoms began to develop years ago. Um, wasn't sure exactly what was going on. As time went on, symptoms got worse. For me, it particularly happened more whenever I would use the bathroom. And so that was a big indicator that we may have something going on with the bladder. And sure enough, I had a paraganglioma in my bladder. And so I was able to connect myself with Dr. Potsock and his team and was able to have it removed almost a year and a month ago today, up at the NIH, and was very happy to have that done and feeling better. And so today I'm here hosting this. Um, and so a couple of things, kind of housing things that we need to talk about. I'll introduce Dr. Potsock here in just a second. But today's webinar is brought to you by the Pheopara Alliance. Our mission is to empower patients with pheochromocytoma and paraganglioma, their families and medical professionals through advocacy, education, and a global community of support while helping to advance research that accelerates treatments and cures. We also want to give a special thanks out to Progenics for making this webinar series possible through an educational grant that they provide. Um, Also would like to right up front let everyone know that we have another webinar on January 13th with a genetic counselor, Samantha Greensberg. So we invite you all to join us on that webinar as well. So we'll be talking about genetics and family implications of results. So you can sign up at pheopara.org for that. Also, feel free to sign up for our e-newsletter at social@Pheopara. We love for you to get some of that information that we send out quite frequently. So today on our agenda, we are doing it's a Q&A with Dr. Potsock. So some of the questions that have been submitted beforehand, and we have gone through those. Some of them are very similar, and if they were very similar questions, we may only ask one that kind of captures the entire picture. So be listening so for your question, because it may be tucked away within another question that we asked today. Let's see, what else do I need to make sure that you know? If you are online with us live right now, you can also submit questions on the chat. And so we have someone monitoring that, and we'll be looking for any additional questions there, and we'll see if we can ask them. We'll try not to get into any specific case questions. We'll try to keep it a little bit more general so that it will apply to more patients and maybe more people who are either diagnosed or worried about a diagnosis of paraganglioma pheochromocytoma. But we'll do our best today, okay? All right, so let me read our disclaimer for today. This information that is presented on this webinar is for educational purposes only and should not substitute the advice of your doctors and medical team because they have in-depth knowledge of your medical history and current situation. All right, now let me introduce Dr. Potsock. He is the chief of the section on medical neuroendocrinology at the National Institute of Child and Human Development. The National Institute of Child Health and Human Development. I'll get this out. Which is one of the largest centers in the world to diagnose and treat patients with Pheopara. Dr. Potsock has dedicated his career to providing the most cutting-edge clinical care and advancing research for Pheopara and he serves on the Pheopara Alliance Medical Advisory Board. Welcome, Dr. Potzak. Hope you are ready to do a Q&A today. All right. So first question.
Oh, first of all, I would say, thank you so much, Dr. Snyder, for the introduction. It's a great pleasure to be here today and honored to be invited by Pheopara Alliance. And I think that we have a good number of patients here. You know, I'm reading the number like 68 or something like that. I think that would be great. I would like to tell everybody, ask me whatever you wish. I will try to answer as many questions as possible. We have approximately 1 hour or less than one hour, but I hope that we will cover the most important questions. So feel free, and whatever you want to ask me, that would be good. If there is something that you have in mind and you would like to talk to me, and your answer will not be actually your question will not be actually mentioned, or you will not be able, to hear something what you want, and you have something very complicated, very special, difficult, you are definitely welcome to send me email, and I will be happy to discuss with you some, very special, for example, situation cases or scenarios later on, and to contact you. I'm pretty sure that everybody has my email, and if not, the Pheopara Alliance will provide you with my email. So I will stop here. As I said, great pleasure to be here before Christmas, and we can maybe start.
All right, excellent. So we're going to start with a small segment on COVID, because it is on everyone's mind right now.
Yeah.
So first question is, do you consider those of us who have had Pheo or Para or currently have it, do you think that we are at a higher risk for getting COVID and or having more severe symptoms from COVID if we got it?
Yeah, so I think that is definitely a great question, and one of the most important during this period. My answer is yes, you are, and it depends what you have. If you had pheochromocytoma paraganglioma and they were removed and you don't have anything else, so definitely not. You are like the same as everybody else in the general population. Whatever, the risk can be, but not related to pheochromocytoma paraganglioma that used to be there before. However, if you have a pheochromocytoma paraganglioma, you may be at a different risk, and you will be into two categories, and you have to answer which category you are in. The first category is if your tumor is functioning. If I talk about the functioning tumor, means that the tumor is actually producing and releasing catecholamines and metanephrines, and here especially catecholamines. So you know whether you are positive for catecholamines or whether you are not. If you are not positive for catecholamines, you will be in a much better scenario versus if you are positive, because those who are positive for catecholamines, what is happening with you? You know that you have a high blood pressure. You have a tachyarrhythmia, which means, your heart is beating fast. So it's affecting your heart. So then, of course, you have a increased glucose. So because catecholamines are affecting glucose and increasing glucose, and some patients, maybe 5 to 10%, are presenting even with very mild diabetes. If you go to COVID patients who actually can get COVID, or what are the problems with, with the COVID in some patients. So those patients who are obese, you know about that. So obesity is not the issue for pheochromocytoma paraganglioma, but they have a hypertension. And this is definitely, they are in much higher risk, those patients that they have a hypertension. Those patients that they have a cardiovascular problems, and here, the problem is heart. So you will have a problem with heart if you have a high catecholamines. And those patients that they have a diabetes, they have also higher risk to get the COVID. And the fourth group of patients are those who they have a, generally speaking, tumor / cancer, and especially if they have a metastatic disease, because everybody who has actually the cancer has a abnormal immune system. The immune system is usually not working so well like in somebody who does not have a cancer. So you will be definitely in the higher risk. I would suggest that we publish the paper, interesting paper about the COVID, catecholamines and pheochromocytoma. The paper was published in Lancet Diabetes and Endocrinology. The paper came out approximately 2 months or 3 months ago. And it's actually interesting paper. I am not supporting my paper, which means because I'm the part of the co-author of the paper, but I think that this paper very nicely summarized, and especially when you look at the table, very nicely summarize what is happening to patients with pheochromocytoma and why they are in higher risk for the COVID compared to those they don't have a pheochromocytoma. But once again, if you have a pheochromocytoma and this non-functional, which means there is no increase catecholamines / metanephrines, you are in much better position than those that they have actually increased catecholamines and they have to be treated for example, arrhythmia or high blood pressure.
Okay, very good. So the next question is, then do you recommend that those with a active Pheopara get the vaccine? And is there a difference in any of the vaccines, one that you might recommend over another?
So I would, overall, I would recommend that the patient will get, that they may consider getting vaccine. Of course, it's up to everybody because everything has pros and cons. Even, those vaccine, and you heard it on the TV, you heard also something from the NIH, that they will be very efficient. It's maybe about 95% or so. And overall, the safety of vaccine or vaccines, it depends which company, will, or pharma will be used. It will be okay. So, but there are some cons as well. For example, you have to be very careful if you have allergies. Okay, so if you are a person with, for example, pheochromocytoma paraganglioma, active tumors, and you know that you have multiple allergies, sometimes you have a very complicated, for example, multi-drug allergies and severe allergies, you also end up sometimes at the emergency room because of allergic reaction for different drugs. Okay, I'm not talking about the food, but different drugs. You have to definitely contact your physicians and talk to the physician what actually can be done. For those patients who thinks that they maybe have a problem, and sometimes you can also ask yourself, did you have any, for example, vaccination against the flu vaccine? Because some of you had maybe flu vaccine and had some consequences, some problems, difficulties that already is red flag to say, yes, I have to be careful. In that scenario, I will talk with the physician, ask him about that, because they will have I'm pretty sure, very good information, and maybe will be a little bit safer to see when vaccination will start, how the different vaccines are working, because there will be information publicly available. And the information will be publicly available very quickly. So even if you get the vaccine 3 weeks later, or let's say even several weeks later, more than 3 weeks, in case that you are not in the situation that really the vaccine needs to be considered, whatever the environment, your environment is, and whatever, I would say there are some reasons for that, then I would definitely wait and see what are the adverse events, what are the consequences of these vaccines, including, for example, allergy. And when you know everything about that, then you will be actually in much better position to choose among vaccine A or B or C. So I would not immediately rush if you are not really in the situation where a vaccine has to be considered because you are working maybe with the people who have a, COVID, or you can be exposed to COVID very quickly because of your work or environment. And I'm pretty sure every physician will tell you. So, but if not, be very careful. Just wait and see, what's going on. Everything will be available, as I said, on social media, internet, many websites, TV, and then to decide. That's what would be my approach in case that you have something behind you that already giving you a red flag that you have to be careful to get the vaccine.
Okay, if you have already had your Pheopara removed and
Yeah.
you don't have any known tumors, in that case, would you recommend going ahead and getting it?
Sure, absolutely, because you are like, it's the same like general population. If you don't have any Pheo, any paraganglioma, you are feeling well. Even if you have some, for example, some genetic problem, like having either red oncogene or VHL or SDHX or something else, doesn't matter, because there is nothing to know that, some genetic background related to pheochromocytoma would affect your decision-making process to get the vaccine. So if you feel okay, you are in good shape, tumors were removed, you are, let's say, at that time, you are cured, so you will be at the same, I would say, at the same level like general population, and you can consider vaccine.
Okay, very good, very good. Now, during this COVID time, there have been a lot of questions about, should I delay my lab work? Should I delay scans because of the risk of potentially getting COVID if I go in for a scan? So what are you recommending right now? Should people hold off on scans and lab work, or is that something they should go ahead and proceed with?
Yeah, this depends on the really personal situation. Those who have a more rapidly progressing tumors, those who are not feeling well, those who are actually in complicated situation that everything is changing every week. We have some patients that even, from one week to another, they are doing worse. So they need definitely help as soon as possible, or they have many metastatic lesions. Some of them are growing, and I would say moderately or even rapidly, they need a care regardless whether there is COVID or not. And they need actually help as soon as possible. Those who feel pretty okay, stable for a longer period of time, and they know that during the last, let's say, 6 months, 12 months, their tumors were stable. I don't think that anything will happen if they will wait a little bit longer. I would not suggest they travel unless they have an option. For example, if they go to some medical center and the medical center is closer to their home, that will be fine. But if they have to travel, and especially if they have to use, for example, they fly from one state to another, and these days flights are, becoming full, not like it used to be a few months ago. You have to be really very careful, and especially again, if you have active tumors, you are on antihypertensive medication, you are, for example, obese, you know that you have a hypertension, you have actually diabetes or higher blood glucose or sugar, that's definitely you have to be careful. Here, I would maybe wait, but it depends where you stand with your disease. Of course, if you need the operation, and here is the also important scenario. Let's say you have a one tumor, you are new to this world, your tumor was diagnosed just recently, you are not feeling well, you have a high blood pressure or episodes of some spells, or almost like hypertensive crisis from time to time. You have a palpitations, also your heart is beating very fast, and sometimes heart rate is over 100, blood pressure is over 150, 160. Here, I would definitely recommend your tumor to be removed, regardless of the COVID or not. So, and there are many centers, including, of course, our institution, that we are actually accepting patients. We see those patients and who need, for example, immediate care. And here I would say operation, and those patients should be operated, definitely. But they have to be very, very careful, and the good care must come not only from physicians but also from the patient. It's a mutual relationship in that scenario, because during the COVID, of course, the both sides may or need to work very closely and support each other to make sure that there will not be actually transmission of the COVID. And many centers, like our centers, we are testing patients who, when they are coming, we are testing patients twice, okay? So it's not only one testing you get two testing, and especially if they are waiting for the operation, to make sure that, to test, and usually, with the two consequent days, like, let's say Monday, Tuesday, just to make sure that there is really no COVID and everything is under certain rules and guidelines.
Okay.
Hmm?
If you have Pheopara and you're waiting on surgery, or maybe you're metastatic and we're just monitoring symptoms, and you get COVID, is there any advice that you might have for that particular patient?
Yes, if you get, it's interesting question, pretty challenging, because it really depends how you are doing. Okay, some patients, they have a COVID and they are in very critical situation, and then critical situation has to be fixed first before any pheochromocytoma paraganglioma. Okay, and especially if there is lung involvement, if there is a COVID and there is something which is mild, of course, and if your operation can be rescheduled, or some diagnostic procedure can be rescheduled, I would definitely reschedule it. Okay, because I would wait when you recover, because you never know if you would do the put patient under anesthesia, doing operation, and you already know that the patient has a COVID, that could be very complicated, very problematic. Okay, if of course that somebody would have some symptoms and signs but not very severe, and the operation is imminent. Some patients, they have a metastatic disease in the brain, okay, and you have to do operation very quickly. Or there is something like fracture of the bone and it needs to be repaired, so because otherwise it would cause major problem. Or somebody has, for example, bleeding or embolization or something, so the treatment needs to be done, and of course precaution will be taken. So it's really based on individual situation. It's very difficult to say that there is, for example, algorithm 1, 2, 3, 4, or the boxes, and you will be in the box 1 or 2 or 3. It's delicate. It really depends how the patient is doing, what are the symptoms, signs, what is the course of the COVID, and whether there is emergency or not in terms of the operation. And the same like, so somebody would have a myocardial infarction, okay, with the pheochromocytoma, and we have those patients that will end up with stroke or myocardial infarction. You have to treat those patients. You cannot say, I will wait after you recover from COVID, because the stroke, in certain types of stroke or myocardial infarction has to be actually treated as soon as possible. So it really depends on the situation.
Okay, thank you. Okay, I think those are our main COVID questions. So let's switch gears a little bit. So, you know, as we all know, diagnosis is hard with these. You know, a lot of people kind of go down a path to try to figure out, is this what I have? Is this what I have? And so a question that comes up a lot is, how out of range should my metanephrines be that would indicate that this is truly what I have?
Hmm. Yeah.
Is there
Oh,
is
so
there a range that you
yeah,
look at?
yeah. So your question is whether biochemical diagnosis can really give you some answer whether you have or you don't have a pheochromocytoma. And my answer, yes, it will. If metanephrines are elevated several times above the upper reference limit, so, and you have a special or some symptoms and signs related to catecholamine excess, which is nervousness, palpitation, hypertension, being pale, sweating, usually brain sweating overnight, anxiety, and you are not taking specific medication that could actually cause these kind of problems, and your hypertension is very difficult to be treated, for example, and then you go to physician and metanephrines are elevated, there is high suspicion for pheochromocytoma. We always recommend to the patients to have either plasma or urine metanephrines. You even don't have to have a catecholamines to be measured, okay? So you need the metanephrines. These are very, very good for the diagnosis. You can choose either one because they are so close that there are almost no differences between the plasma and urine metanephrines. And if they will be elevated, let's say 5, 6, 7, 8 times, I guarantee you that you will have a pheochromocytoma paraganglioma. If they are elevated, let's say 3 times above the upper reference limit, there is high suspicion, but it can be also related to some drugs. And remember, the drugs that there are the worst drugs that they can, one of the worst drugs, I cannot say maybe the worst because we have never tried to test all the drugs, you know, because it's impossible, are antidepressants. Okay, patients are on antidepressants, or population here in US, 20–30% of people, general population, based on the literature, I hope I am correct, you know, are taking some antidepressants, and they can increase metanephrines, plasma metanephrines 3 times, even more above the upper reference limit. That's the problem, because those patients can present with hypertension, palpitations, and they can have elevated metanephrines, but it's because of the antidepressants. And if it is maybe 2 times above the upper reference limit, the likelihood is, there is some likelihood, but you know, lower. And then it depends what the physician will do. Usually we suggest to stop medication, but some patients cannot stop the medication. And if they cannot stop medication, we have some test which is called Clonidine suppression test, and it cannot be done in everybody, but in many patients it can be done and tell you whether pheochromocytoma is real or not. And if this will come positive, then immediately you go to imaging. Okay, so that's very important. So remember, you know, the teaching point for all the patients, remember, medication, 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 that can cause false positive results. And those false positive results are very common, actually. So I think more patients have a false positive results than they have a real pheochromocytoma.
If then the metanephrines are in that sort of, we'll say, questionable kind of area, and you say then the next thing really should be imaging, what is your go-to imaging that you would recommend first?
Yeah, so imaging is either CT or MRI. So I prefer CT scan because CT scan is very quick. CT scan can do the whole body. It's done in a few minutes. Of course, the preparation for CT scan is not in a few minutes, But otherwise, it can be done as a whole body scan, and it can be done one session, one visit to the radiology department. The MRI, it can be done, but you will never get MRI of the whole body. You have to come to a radiology department several times. It's maybe more expensive, more complicated, but it's preferable. In some patients, like, of course, pregnant women would never get the CT scan. Okay, so we know about it. If you have some allergy to contrast dye, for the CT, you will not get the CT, you will have the MRI. For the children, you have to think, whether CT or MRI. Okay, so sometimes we prefer MRI, but really it depends. Okay. And of course, we have some patients who had a lot of radiation before, whether they had some different tumor, whether they had before, for example, metastatic disease and they were cured almost, or the tumors, everything was stabilized and they had a lot of scan. So we try to limit, and especially for children, we try to limit the amount of radiation, because every CT is definitely some amount of radiation. So it really depends. But honestly, I prefer the CT, and if CT will show something in the area where I know that MRI is better, for example, for the chest, for the cardiac paraganglioma, for the head and neck paraganglioma, then I will definitely go with the MRI. So sometimes you have to have the MRI like add-on, okay? So you go with the CT, you scan the patient, you know what's going on, you find something that is worrisome, and then depends on the location. And the location will tell you whether, to add the MRI or not. And as I said, there are some specific locations, and I mentioned some of them.
Okay, very good. Good information. Okay, so this next question that's coming in is about Sdhb. So someone who has a genetic mutation. How often should this person get MRIs and biochemical testing? And then what about their kids if they have kids? So if they have that gene, how often?
Yeah. So if somebody has a Sdhb mutation, let's say somebody will be adult patient, so definitely you have to have every year plasma or urine metanephrines. That's absolutely must. Okay, once you get the diagnosis of Sdhb, even if you don't have a tumor, you are so-called carrier, you have to do it every year until the rest of your life. Okay. In terms of imaging, so usually you get the imaging for the first time. Again, you can get CT or MRI. I would suggest CT scan, as I told you about it before and what the reasons are. And then if everything is okay, you can repeat the scan in approximately 3 years. Here we go. If every 3 years, you have two options. Every 3 years to do the CT scan, or you tell yourself, let's say you are 20 years old, so how many scans you will have if you will live until, let's say 80, so you will have, every 3 years, 20 times, so that will be a lot of radiation. So right. What we sometimes recommend is you do the CT scan for the first time, and then you alternate. You do the MRI or you do the CT scan, every 3 years, and you alternate. So you will reduce amount of radiation. So the accumulation, the total dose of radiation will be half, because you actually alternate with the MRI. And that's very important. The second one is that, you have a, for example, child, and the child will be diagnosed, and for the Sdhb. So you can start with the metanephrines approximately at age 5. It depends when the diagnosis of Sdhb will be done. But let's say at the age of 5. And then you should start with the first scan approximately between the 5 and 10 years old. There are new guidelines for all the patients who are just now on this webinar. There was an excellent study that is done by French actually group, and we were very happy to be involved in this study as the NIH, and there are also some other medical centers that are involved, including, for example, Mayo Clinic and other centers from Holland. And the study is coming in Nature Review, I think Nature Review Endocrinology. I hope that I did correct. And the study is coming very soon. Please look at that study because it's addressing carriers, including children, and not only SDHB, SDHD, SDHC, SDHA. It's a very, very good study. Of course, it's suggestion, it's a proposal, it's not very typical guidelines, because we would need, to take a little bit different approach. But I think it's very good suggestion for the patients, but also for healthcare professionals, what to do if somebody is carrier of certain gene. Here, the study is related to SDHX. X means ABCD.
Right. Now, is it true that we are still learning about SDHA, or do we know a lot about that?
We don't know so much about that, although there are some interesting studies about SDHA. Some study came, I think, from from Michigan, from Dr. Els, Dr. Fishbane. The study came also from NIH. I think one study is from Holland. And so not too many studies. And the reason is that patients with SDHA, if they have a mutation, so if, and I just got, I think, 3 or 4 emails during the last 2 weeks. I have a patient with SDHA mutation. I don't know what to do because patient has this mutation, most likely is pathogenic, but never had any symptom signs related to the presence of pheochromocytoma. I wanted to tell you, don't be very scared if you have a SDHA mutation, because the penetrance of this gene and actually to develop in really active disease, it's very low. The chance, the likelihood to have actually pheochromocytoma paraganglioma if you have a SDHA is extremely low. Okay, so I would say it's very, very low. Okay, so in that case, there are sometimes a lot of worries, but it's not like for SDHB. If you have a SDHB, your chance, it depends what you read, is 20%, 30%. For SDHA will be less than 5%, maybe even less than, more than 5%, maybe 3-2%. But for the SDHB is definitely many, many times higher. That's the problem. SDHB is the problem, but the SDHA is not so big problem. Of course, if you develop pheo or paraganglioma related to SDHA, then there is a problem, because sure, SDHA tumors, at least based on the study that we actually put together, it's not easy to be treated. We sometimes feel that it's easy, but it's not, okay? And it's maybe sometimes even more challenging in certain way than patients that who have a SDHB, okay? And we still don't know what is the reason, because the studies, as you, Dr. Snyder, as you said at the beginning, so there are not too many studies. Everything is limited. So we need more experience, more knowledge about these tumors. But this is where it is heading, approximately.
And if we look at C and D compared to A and B, where do they sort of fall on the spectrum?
So C is not, I don't consider C as a problematic. We have some patient with C, but definitely not something that is very problematic. Of course, they may develop metastatic disease, but overall, I think that these tumors are not behaving so badly. For the D, it depends. Previously, we saw that the D has low metastatic potential, but there was, I think, nice study that came from French group from Paris, and they actually look at the patient with Sdhb mutation, and they found that this is definitely much higher in terms of the metastatic disease, the rate for likelihood to develop metastatic disease and to present with metastatic disease than before. So maybe we would be somewhere around 20% or so with those patients with Sdhb. And if they have only head and neck paragangliomas, that is much better than, for example, if they have something which is below the neck. Usually, so I think that C is maybe, and this is my personal view, okay? Many may not agree with me, and I understand because, these are rare tumors, we still need more experience, but C I consider as the best one. D is a little bit more complicated. B I consider as a bad. B as a bad, okay, and A sometimes I consider as a awful, because the patients, even there are very few patients with SDHA metastatic Pheopara ganglioma, but they have difficulties in terms of responses to therapies, whether it's chemotherapy or radiotherapy. This is our very limited experience at the present time.
Good. That was a great explanation. I think that's going to help a lot of people. I recently heard on the support group one patient. She was older, in her 60s, and she had, I don't know which SDH mutation she had, but she was told, not by you, of course, but by one of her doctors, that because she was 60, she had the mutation, but she had never had a tumor, that she would never develop one. What do you think about that? Can you be older and have any of those mutations, and that you could still develop one in old age, or no?
You definitely can, and especially when you are 60 years old. We have many patients who develop tumor around 60s. If you are going to 70s, 80s, you can maybe, and if the patients did not develop any tumor around the 80s, you can even stop doing this regular scanning and everything, or you can a little bit skip, let's say 1 year or so, because the likelihood at that age is very low. We had few patients, very, very few, but it's very, very, very unusual, okay? The same is like to have somebody, the child, to have pheochromocytoma at age 2 or 3 or 4, it's almost non-existing. But if you are 5 and over 5, then the problem is starting, and especially for SDHB, because you can actually have the tumor, and we have few children that they develop the paraganglioma / pheochromocytoma around age 5 or 6. So really, you have the categories like, this is like Gaussian curve. You are at the beginning, you will not have a pheo until the age about 5 or so. There are exceptions, of course, and we know that there are exceptions. Nothing is 100%. Medicine is never 100%. And you have also patients 80 years old and they develop the tumor, but it's a rare event, okay? So that's how you have to take it. But if you are 60, today when you are 60, you have still a pretty good chance to develop pheochromocytoma paraganglioma. I would definitely not stop at that age.
Okay, very good. Okay, so this question has come in. Since adrenal medullary hyperplasia can be a precursor to Pheo, Can you comment on the diagnosis and treatment of it?
Ah, that's interesting. That's interesting question. There are mainly two scenarios. One scenario is for red oncogene, MEN to A or to B. And the second one is for succinate dehydrogenase. It was, for example, described for Sdhb. They can have a hyperplasia. If they have a hyperplasia, they will have a symptoms and signs of catecholamine excess. Not everybody, but some of them they will have. So they will come to the doctor, they will tell them, sometimes they have a spells. And when they did, when they will do the CT scan, here I would suggest CT scan, not MRI. I would say CT scan with, we call it like thin cuts. Those thin cuts is 1.1, 1.2 millimeter, you know, to really see very well the adrenal gland and see the hyperplasia. So, and they will tell them, yes, your adrenal is a little bit thicker, is a little bit bigger. So, and that's, and you know that you have this mutation because of your family members or for some other reasons. That's actually can be the scenario. What to do with those patients? Nobody will operate on you at the present time because you know, you never know whether you will get pheochromocytoma or not, but I will guarantee you that if you have a MEN, you will get pheochromocytoma sooner or later. And if you have a Sdhb, most likely you will get it as well. But because it's hyperplasia, because it's not small nodule, you know, so that would be very complicated to get anybody to operate on you. And this is not the current practice. But what you will need, because you will already have a symptoms and signs, and you are not feeling well from time to time because you have those spells, you will need a medication to counteract the effect of catecholamines, which would be, for example, the alpha blocker or alpha and beta blocker. So that would be something that I would suggest. Very mild doses, very, very, very low doses, very, very, very low doses. Okay, but you may need it, and then to have regular scans and to see what's going on, because sooner or later, most of these patients will develop pheochromocytoma.
Okay.
Right?
Okay.
If they have a genetic background. If they don't have a genetic background, they have a medullary hyperplasia. We don't know what is the reason here, and most likely they will not develop anything, and they will need to be on some medication that will counteract some effects of catecholamines if the catecholamines / metanephrines are elevated either in plasma or urine during the regular biochemical testing.
Okay. Okay. All right. So next question. How can those with active Pheo and elevated fasting blood glucose reduce fasting glucose? I'm already on a very low carb diet. Would this indicate alpha or beta blockers need to be increased?
Yeah. So that's interesting question. So I would ask, you know, the low carb diet, that's fine. So what about, you know, the physical activity? Physical activity is very, very good. I would not recommend strenuous physical activity, but for example, walking and even some brisk walking, if, you know, everything is fine, that you don't have, for example, just suddenly some spells. I think that that would be good, and it's very helpful because, you know, when you do the brisk walking, you know, you will use practically all muscles. 70–80% of your muscles will be used in your body. They are actually, they need the glucose, okay? So it would be definitely helpful to manage your elevated glucose because you are already on diet. Diet never helps. I mean, diet helps, but diet never helps if we are talking only a diet. You have to add something else, and that something else is physical activity. Of course, not everybody can do certain physical activity. Somebody has, for example, arthrosis. Somebody is after a back operation, something else. And then, of course, you know, some patients, they will need some medication, whether they will need some peroral medication, antidiabetics or insulin. And we have some patients on those, either one, either insulin or some tablets to help them with the blood glucose. But the good thing is, if you have something which is like solitary tumor, one tumor, and then you are waiting for operation, everything will disappear after the operation. Okay, if you don't have it, and you have, for example, metastatic disease, there won't be any chance whatsoever to normalize the glucose the way that we wish. Yes, you will try to normalize it. As you said, you have a low carb diet. I talk about physical activity, medication, also some antihypertensives that we are counteracting, the effect of catecholamines, which would be helpful. But I don't think that there will be normalization if we talk about metastatic disease.
Okay. You mentioned symptoms, and after surgery, symptoms go away. How long? How long? I don't know. I don't know if you remember, but after my surgery, it took me quite a while, I feel like, to really get my symptoms to just sort of tamp down. And I can't tell you what was going on, but I felt like I was still having spells. And there are many people out on the support group that after their surgery, they would sort of report the same thing. They feel like they know their tumor is gone, but they continue to have sort of random spells here and there. So what's your timeline, and what can you say about that? How long? And
you will be very unusual to have a symptoms and signs related to pheochromocytoma after surgery if surgery was successful. If surgery was successful and tumor was removed successfully, so the patient is at that time is cured. Let's say the patient has only one solitary tumor, so would be very unusual. So of course, the effect of some previous medication, anesthetics, everything what the patient had may actually change a little bit how the body is working. And I would say that that would be maybe for 2 weeks, 3 weeks. But the relief from catecholamines is immediate. It's actually already at the OR. Of course, you don't know anything about it because you are sleeping when they are operating on you. But immediately the catecholamines are practically normalized. They are not normalized because the patient is exposed during operation to stress, anesthetics and everything. So of course, although they would be like normalized, they are not, because the catecholamines are not released only from pheochromocytoma. They are released from your nerves, okay, sympathetic nerves. And those sympathetic nerves are in the whole body. Why somebody has a spells and does not have a pheochromocytoma, the patient is anxious, or somebody is anxious, somebody is exposed to very complicated physical, psychological stress, and they have the same symptom signs like somebody who has a pheochromocytoma. But, it should normalize in a few weeks, 2-3 weeks, definitely. And then this is why we suggest at least 3 weeks to wait to repeat the measurement of metanephrines and catecholamines after surgery. Here at the NIH, we usually do 4 to 6 weeks, but some institution may take a little bit shorter period of time, but should be okay. What is the reason why the patients have still some problems later on? I don't know. It's they may have we described many years ago and published something about the withdrawal syndrome. So like, you are a smoker, you are drinking alcohol, you are doing something else, having, some opioids. And here you have a catecholamines, high catecholamines, and you just have a withdrawal syndrome because the catecholamines that are very high, just in a 1 minute when the pheo is removed, so are normal, are very, and if not normal, so are very, very low compared to the previous level before the tumor was removed. And some patient may have a withdrawal syndrome, and those patients may present sometimes with the palpitations, with something like feeling that there is a spell, something like that, but it's not typical Pheo, it's the withdrawal, and they have to put their body in certain equilibrium, okay? So any balance, and that sometimes takes time, and that's maybe the reason, okay?
That makes the most sense to me, and would probably describe what I went through. And I know there are other people on the support group who have had those same, they had their surgery and it was successful, but yet they still feel like, it takes several months. It took me several months to really feel like my equilibrium was coming back.
Yeah,
So
because
that makes the most sense to me.
they have to adjust their body. The body has to be adjusted, because some of them, they have been with the Pheo for 5-6 years.
Right.
And this is the same like you have a smokers. They stop smoking, does not mean that they feel well, they feel miserable. Some of them feel miserable. Not only that they have a craving at everything in terms of, having cigarettes, unless they are using some medication, but they still don't feel okay. They need many months actually to put everything in the normal function. So, and to establish certain balance in the body.
Yes, that makes a lot of sense to me. I apologize if you hear my dog in the background. I think she wants to go.
We like dogs. That's okay. That's
Right.
fine.
Good.
There are some dogs, actually. I don't know if our patients know, but there was something about the dogs, or at least that there was some report a few years ago, that they can actually find somebody who has active pheochromocytoma paraganglioma. Okay.
Wow.
And it's most likely it's correct, because there are different dogs that they are actually able to diagnose, or to select some patients who may have a cancer, different type of cancer. But this was something about pheochromocytoma paraganglioma. So there are some.
Very good. Okay, so we're getting close to our time here. So we'll do one more. Any promising research?
We can do maybe 2 or 3 more.
Okay.
I don't mind if patients will stay around. I can stay around with them as well. So I can answer more questions. I think that would be okay with me.
Okay, then let me ask you another one. So I've heard from a lot of females who feel like, because this is an endocrine, these tumors sort of mess with your endocrine system. They have a lot of questions about menopause and the effects that the tumors have on that, and maybe their reproductive system. Well, just what in general, what are your thoughts about that?
Yeah, so having pheochromocytoma, especially those symptoms and signs to catecholamine excess, very often resemble somebody who may be perimenopausal. And I know several patients who were misdiagnosed, and unfortunately, sadly misdiagnosed, because they were at the age that they were told, "Oh, you are perimenopausal. You may have, this kind of problems. Maybe you have also stress at work, so, and maybe it will be good if you take some break, take vacation, take a beta blocker. Beta blocker does not help, actually makes things worse. Never use beta blocker first. Remember that." And so unfortunately, there are some similarities. Whether somebody has a palpitation, somebody has, for example, headache, sweating. Sweating is another actually problem. Some nausea, vomiting that some patients may have. So definitely you have to be very, very careful here to put somebody into the category, for example, perimenopausal, because of the age, and because a woman will or has irregular periods. and we think, oh, this is only this problem. You have to be very careful. Here, what I would suggest to look at the blood pressure very carefully and heart rate, because for the perimenopausal women, you should not have a very problematic changes in the blood pressure and heart rate. You can have a sweating, you can have sometimes palpitations, which are also in Pheo. You can have a little bit, as I said, some nausea, some headache that are with hypertension. But if you measure blood pressure well and on regular occasions, for example, 3 times a day for longer period of time, and you see that even if you don't have a problems, your blood pressure is still elevated, your heart rate is still elevated, and also glucose. What we talk about diabetes, the glucose can be slightly elevated as well. Although which is not easy to measure glucose unless you have some glucometer, for example, at home. So then it's worrisome, and you have to tell your doctor. So I want to be tested also for Pheopara ganglioma to be ruled out.
Okay. Do you think that those women who have had their tumors removed are at a higher risk for early menopause, or have you seen any connections there?
No, there is no connection, at least to my best knowledge, unless the tumor would be in some location that would affect, so ovarian function, or because, the tumor can be in, for example, in ovary, and, and other locations, but otherwise, no. No, there is no, to my best knowledge, there is no connection.
Okay. All right, good. So let me go to another one. Why do some family members with the mutation get tumors while others who also have the mutation don't get any tumors?
Yeah, if I would know, that is 1 million questions, and the answer, that would be good. That would be, close to Nobel Prize. Okay, so unfortunately, this question is fantastic, wonderful question. I appreciate it, but we don't know. We are working on that for many years. Many physicians and scientists are working on that, and we don't know. Okay, so there is definitely some second event, third event, another events that are happening. I don't think it's for example, if you have a Sdhb mutation, why do you develop a tumor? You develop it, and your relative who has also Sdhb and or sibling does not have it, because there is some other event in the cell. Okay, so whether it is something outside genetic material, epigenetic and affecting genetic material, microenvironment, okay, or something else, we don't know yet. There are, of course, some theories, and people are looking at that. What we know, for example, that patient with Sdhb will be more sensitive to low oxygen level. Okay, if I take the Sdhb patients and put them in Colorado, by the way, wonderful state, but if you go, for example, A Basin, which is, almost the highest, for the skiing, and you will be really great skier, and you love A Basin, and you will spend there 2 months, even if you have Sdhb mutation, I will not be very happy to hear about that, okay? Because I think that you will actually promote or you will support your cells that already have mutation to transfer into tumor cells, okay? So that's what I feel, for example, in the about the hypoxia. And especially for a patient, for example, that they have a Sdhb or Sdhd mutation. And but this is only about the hypoxia here, so something that, I'm talking about Colorado, but there are many other events that we don't know that are happening and contributing to development of the tumor. And we are working on that. Many others are working on that, but there is not something that we we would really very much know at the present time. I think it's the combination of several factors before the cell is becoming tumorous. So we cannot help you just now. Some they say that if you have a very good antioxidants and everything, very good diet, very good physical activity, not the physical activity, that you will be short of breath, okay? Because you will be hypoxic, okay? So I don't think that would be good. This is my personal view, many would maybe not agree with me, but this is my personal view. So you will definitely help yourself. And of course, stress is playing an important role, but not everybody is lucky to have a job without stress. I can tell you, we all are under stress sometimes because it's a lot of work. So it's difficult, and nowadays the environment and everything, and when everything is very complicated, difficult, and on the top of that, the COVID, makes the things a little bit even or maybe much more difficult than used to be before. But trying to balance everything as much as possible, even if sometimes it's not easy.
You sort of mentioned this a little bit. Do you recommend to take or to stay away from any particular supplements or anything that, like on the amino acid chain, one way or another, you recommend or you don't recommend something?
With the supplements, no, not really. We never really thought about that in terms of supplements. I don't think that would be any problem with supplements. Of course, there are many supplements for many reasons and everything. I sometimes feel that, for example, to maintain good immune function, to boost the immune function, it's most likely, can be helpful. But of course, there might be supplements that will increase the blood pressure, supplements that they can affect your heart rate. They can even affect your glucose. So you have to be careful what you will take. But since there are hundreds or thousands of supplements, it will need to be discussed on an individual basis, but not something that I would say it would be, put this way, would be very, very complicated, or I would be aware of something that I would tell you, definitely not, don't take this supplement because that could cause the problem. Of course, some supplements, as I said, they may have some steroid effect, okay, that they may have the effect of and affecting blood pressure, affecting heart rate. Then you have to be pretty careful, okay?
Right. And we talk a lot about the tyramine diet, and trying to keep a low tyramine diet. So that would be an example.
That would be example. That would
Right.
be example, because tyramine will definitely, increase the blood pressure. There is also over-the-counter medication, which of course it's not like supplements, but can increase blood pressure, including cold medication. So you have to be aware of that. And that I would definitely be careful there. But usually it's written there whether that can affect, for example, blood pressure, heart rate, glucose, and especially for patients with active pheochromocytoma, functioning pheochromocytoma. What is the most complicated situation? Myocardial infarction, stroke, okay? So, and you will always get this information with supplement, whether they can increase the heart rate and whether they can increase, for example, the blood pressure, and whether actually increase coagulation, okay? Because catecholamines can actually lead to thrombosis. If somebody has a high catecholamines, this is prothrombotic actually environment. So you have to be very careful if they say that, that's somebody taking supplement and that can be prothrombotic characteristic property, that's definitely you have to be very careful. And including some estrogens preparations, because the women are taking estrogens and they can actually, especially estrogen smoking, so, and that can be problematic with thrombotic events. And if you have a pheochromocytoma, not only that smoking is releasing catecholamines, that would be bad, but also catecholamines are prothrombotic. Okay, yes. So that you will have a scenario that you will end up with very complicated and difficult situation. Not everybody, it can be 1 out of 10 or 20, 30, 40, I don't know. There is no study, but definitely not the situation that I would suggest.
Yes. So if it says may cause clotting,
yes,
stay away from that.
Yeah, may cause clotting, so you have to be very, very careful, especially when you have a functioning pheochromocytoma paraganglion. Functioning again means that there is a production of catecholamines, and catecholamines are released in circulation, so they can have a prothrombotic characteristics.
Okay, this is going to be our last one. Any new promising research out there that we need to know about?
Oh, of course, there is some promising research. And the promising research is mainly, I would say, for patients with pheochromocytoma paraganglioma, what I would say, the research about the imaging. So we know that the imaging is very good. We are able to diagnose. If you take CT and MRI and took functional imaging for patient is here, you have a positron emission tomography. So we can diagnose, I would say, over 90% of tumors. So we are very accurate with the diagnosis these days. But what we want to do in terms of imaging, I think that there would be using artificial intelligence. For example, you are coming with pheochromocytoma in the adrenal gland, and you are 20 years old, you have a 4 centimeter pheochromocytoma. Can we use the artificial intelligence? So which means that can we really map the tumor every millimeter, square millimeter, or cubic millimeter almost? And can we actually make it very sophisticated with some programs to predict whether your tumor can become metastatic? Even the tumor will be removed. You still don't know, and you worry because you are 20 years old and you have 4 or 5 centimeter tumor. What is actually your likelihood to get or to develop metastatic disease in the future? So that's what I think that would be something that we will be looking at, and other institutions as well. Also, to find out if somebody has a tumor in a different location, sometimes we don't know whether it's metastatic or whether it's multiple tumor, multiplicity. Okay, because it's in the location that can be considered as a multiple, which means the patient had, for example, adrenals in the chest in some area, except for lymph node. Everything what is lymph node is metastatic. But it's in some area that you are not absolutely sure. So also using artificial intelligence. Another option is that, let's say you are presenting to the physician and you have a tumor 5 centimeter, tumor is producing norepinephrine, producing normetanephrine, producing methoxytyramine. You have a Sdhb mutation. You have in the tumor some necrosis, your age, your gender. So we are trying to, not us only, there's several groups trying to put together the algorithm that if we put all the information together at the clinic, let's say you are at the clinic. So I will have a small computer and you are talking to me and I will put all the information there. And then I will have a table and in the table I will put all the information and then I click. And before you leave the office, we will tell you what is the likelihood that this type of the tumor, based on the information you told us, may become metastatic. Because I think it's very important, okay? And there are several groups and initiated very well, you know, from University of Dresden and collaborating with them. And I think that that would be something good. For also pheoparaganglioma, for those they have a metastatic disease, I wanted to tell you that there will be some clinical trials. And one of them will be, for example, hopefully, if everything is okay, will be new trial with temozolomide and PARP inhibitors. That will be actually open not only at the NIH but several centers because it's like a national study and under, I think, Cancer Network or how it's called. And I think that that would be good. So patient with metastatic disease will have another option, you know, to be treated with certain combination that can be very good, and that combination that can be very useful. And there are some other clinical trials that are in the pipeline. I think MD Anderson is very good, also in the clinical trials for the metastatic pheoparaganglioma. There will be definitely immunotherapies, combination with some other therapies to see, you know, whether patients with metastatic and especially difficult to treat metastatic pheochromocytoma can be treated and can be treated successfully. So, so several clinical trials are either in the pipeline or under the, you know, regulatory phase, approvals, some reviews. But I think that that would be definitely another option, or other options, you know, how we can treat those tumors. And from molecular biology, of course, you know, it's looking for some specific new pathway in the tumors. We call them signaling pathway. That would be actually important to get not only new biomarkers for these tumors, which would be very interesting, but also to get even additional new treatment options. So I could continue further with certain things, but that's what I think is very, very interesting. It can be very important for patients in terms of their diagnosis, as well as treatment options and outcomes. And of course, I would finish that our dream is how to prevent development of pheochromocytoma paraganglioma. We are not there yet. I wish, I really wish. But we are not there yet, but I'm telling you that there will be time that we will know more about the developmental issues, how everything is happening, what is going on, and hopefully, you know, the prevention to for the in terms of pheoparaganglioma development will be actually reality. But it will, of course, it will take some time. Okay.
Well, you have given a lot of patients more hope today, I'm sure, as they've heard about this new, exciting artificial intelligence and more clinical trials. So that's good. That goes a long way with patients, having hope. So that's good. That's good. We want to thank you today for your time, and for those who are watching, this has been recorded, and it will be out on our YouTube channel very soon. So if you know someone who wasn't able to make it today, they can come and watch it again at any time. And Dr. Potsock, we just thank you so much, and I'm so glad that you're my doctor.
Thank you so much. It was really a pleasure, having me today, and I hope that I answer at least some questions from the audience. I'm pretty sure that there were many more questions, but as I said at the beginning, if you feel that you need to talk to me and you have some very important question or something that you need to discuss with me, just let me know. You know that I always answer, and I will be happy to be in touch with you, and especially if you have something really important, imminent, something needs to be addressed very soon, I will be happy to talk to you, or I will even talk to you over the phone, or everything is virtual today, so we will have some virtual meeting. And finally, I would like to wish everybody very happy holiday season and a very happy and successful new year. I hope that there will be a little bit different year in terms of, things that they are around these days, as you know, with the COVID and everything. However, if you did well with your health, and despite the COVID, I wish you at least to be the same, okay? So,
Yeah.
because I think that would be good, since I always tell, if there is these tumors are stabilized, this is also the victory, okay? And it's good. So, in case that you did very well, and as I said, despite what is happening in this whole world with the COVID, I wish you to be everything at least the same way, or even better. And there are my wishes, for you for the next year, and be well and good, and have very good people around you and very good support.
And we wish you a happy holiday as well. Tell everyone at NIH we said hi.
Thank you. Take care.
All right. Bye-bye.
Bye-bye.